who underwent lung lobectomy using thoracic epidural. Following surgery, he had hypotension, cardia, and desaturation. What are your differentials here?
So given the patient history of hypotension and bradycardia, I would be worried about shock, distributive shock, obstructive shock secondary to hemothorax and pneumothorax, and post-operative hypovolemic shock. Another thing that I'd also be worried about is the high epidural block, which would cause either paralysis to the diaphragm or the intercostal muscles.
That's right. So lots of differentials, but epidural block will be your top differential, and also the shock as well. What are the complications of epidural anesthesia?
So the complications would be the local anesthetic being injected into the systemic circulation, so the blood vessels. So this would cause local anesthetic toxicity, so perioral numbness, metallic seizure, and tachycardia. The anesthetic also be injected into the subarachnoid space. So this can cause hypotension, bradycardia, and paralysis of the diaphragm. And then you can also have post-procedural complications such as a headache.
So, I mean, it happened due to multiple reasons, like toxicity or epidural hypotension, or the inadvertent spinal block, or the high total spinal anesthesia. And I think you mentioned that in the subarachnoid space, but this one is the one that they seem to ask a little bit more about. Patient will come with hypotension, bradycardia, diaphragmatic paralysis, and the symptoms of that is dyspnea, difficult speaking, difficulty in breathing, and you need to stop the infusion, vasopressors, and reverse to Trendelenburg position to make sure that your patient is well perfused. Why does the patient have bradycardia?
So the patient has bradycardia because of the high epidural block. Subsequently, because of this, they will have the blockage of the sympathetic fibers of the thoracic region from which the cardio axillary, and because of that, they'd get unopposed blockage of vagus nerve, which is your parasympathetic system or chain.
What's your management plan in this patient, which we just mentioned about?
Yeah, so the patient is hypotensive and bradycardic. I would be worried here that this is potentially a peri-arrest. I'd manage them according to protocol, put out a peri-arrest call. I'd sit the patient upright, give them high flow oxygen via 15 litres non-rebreathable mask. I'd stop any ongoing infusions, the epidural. I would give on callering that was responsible for the procedure and the anaesthetic team as well, and ITU. I'd consider giving them inotropic support such as epinephrine, metaraminol, and chronotropics such as atropine.
Yeah. So I think you've done it well. They're mainly looking into the initial management of this, talking about CRISP protocol and the escalation, right? Metaraminol and phenylephrine and epinephrine. It's good to mention, but not necessary, to be honest. That will be up to ITU to decide. Okay. Factors affecting epidural efficiency.
So the patient factors would be age and weight, and the procedural factors would be the posture of the patient, the volume of the drug, the type of medication, and the dose of the drug injected, and also the efficacy of metabolism.
Why do you think epidural is sometimes preferred?
So an epidural is sometimes preferred and most commonly used now in the UK for its enhanced recovery pathway. It helps with patient mortality and morbidity as they're able to mobilize quickly and reduce level of DVT. They also have very good outcomes and can also be used to anesthetic and analgesia as well.
And how will you test the level of block?
So we can test the level of block using cold ice packs or ethanol chloride spray.
And how do you use temperature sensation rather than pinprick sensation?
So temperature sensation is used over pinprick because pinprick can increase the risk of infection. It can cause pain and it can cause bleeding.
Very good. How do you differentiate by high epidural block from block?
So a high epidural block will cause bradycardia. Patients will typically be well perfused distally and have warm and pink peripheries, whereas in hypovolemic shock, they'll be tachycardic due to the increase in systemic vascular resistance, and they'll also be cold and clammy.
Yeah. Okay. Overall, good performance in this one as well. There's nothing really to add. I think you covered the main points. And okay, that will be probably it. The rest we can eventually defer to
Yes.
Till next time.
Thank you.
Stop recording now.